Okay, so let's keep going, and let's look at various other uh, anticoagulants that we can give. So let's start with the next most common one we know, which is heparin and the low molecular weight heparins. And we know how this works. It acts by binding to antithrombin 3 through a conformational change. And now activated antithrombin 3 will inactivate factor 10, and it also inactivates thrombin. And so I've depicted the same thing over here. And of note, heparin is one of the most negatively charged ions in the body. And you probably already know how we reverse this. So you take the sperm from salmon, and from this you derive protamine, which happens to have a highly positive charge. And so these two things are obviously going to bind together, and when they do, heparin no longer is going to act on antithrombin 3, and so therefore it disrupts its effect. And so the treatment for heparin to anticoagulate is going to be protamine, 1 milligram given for every 100 units of heparin that were given in the past 4 hours. Now, protamine is very short acting, and some people will get anaphylactoid reactions from it. And it doesn't come predominantly from salmon sperm anymore. It comes through recombinant technology. So now let's look at another one. Let's take a look at this one, dabigatran, which is the direct thrombin inhibitor. And as of now, 2012, this is used primarily in patients who have atrial fibrillation in order to prevent strokes. Now, people like this drug because there's no need to check INRs. So in that way, it's an easier drug to administer. You don't have to keep coming every week to the Coumadin clinic. Unfortunately, there's really no good way to reverse it. In some animal studies, PCCs worked because there are small amounts of thrombin in those PCCs. But unfortunately, there's no real such thing as a purified thrombin concentrate. So with the dabigatran, you could try the PCCs, you could try FFP, but there are really no reversal agents. So now let's look at this one, Rivaroxaban, which is used to prevent DVTs in people who had recently undergone hip or knee replacement surgery, and also in Europe they use it for prevention of PE in patients with DVT, so really the treatment of DVT in adults. It is a direct 10A inhibitor, we said. And for this one, again, there unfortunately is no reversal agent. Protamine doesn't work, right, because that has to bind heparin, and we're not even using heparin here. Now, in some animal studies, again, PCCs may have helped because PCCs do contain some factor 10, but this hasn't been studied in humans. Now, what about if you got someone who's bleeding after you gave them TPA? Now, remember how TPA works? It affects plasmin, it activates plasmin, which then goes and breaks down fibrin. So with TPA, we're going to ultimately end up with a deficiency of fibrin, which is necessary for stabilizing the clot. Now, one good thing about TPA is it has a very short half-life. It's like 90 seconds. So obviously the first thing you have to do is just shut off the TPA infusion. And another thing that you could give to these patients is cryoprecipitate, which can be thought of as frozen fibrinogen. So let me tell you how we make that. Well, not us, but the blood bank. So you take some fresh frozen plasma. See these little icicles on there, see, showing that it's frozen. And you're going to thaw it at just above freezing, so you get a little bit of it. Then you take that product and you centrifuge it. And you take that precipitate and you suspend it in some saline or a small amount of plasma. And then you refreeze it. And this is going to be full of factor 8 and fibrinogen. So for bleeding with TPA, you're going to give cryoprecipitate, maybe 10 units. The rest of their coagulation cascade is also destroyed, so you might want to give them other stuff too to kind of rebuild their coagulation system. So maybe 2 units of FFP, platelets, and even throw in some factor 7 for good measure. Okay, so we looked at heparin so far, warfarin, rivaroxaban, and dabigatran, and even TPA. Now let's move on to some of the drugs that we use during primary hemostasis. So let's look at the first one, the aspirin. And we know that aspirin irreversibly poisons platelets. So even after aspirin is long gone from the system, those platelets are not working. So the treatment's easy. Give them platelets, thereby replacing those ones that are bad. And for minor bleeds like epistaxis, you can give DDAVP, desmopressin. So that would be for your patient who comes in on aspirin who has a nosebleed, which won't stop. Now, what about drugs like these, like Clopidogrel? And this also irreversibly damages platelets, though this time through the ADP receptor. And this will also require platelets to be given, usually more than 2 units. Okay, let's look at one more. Let's look at these, like abciximab. And this abciximab is an immunoglobulin that will grab the 2B3A receptor. And while the drug itself stays in the blood for only a short time, maybe like 10-15 minutes, when bound here, it can stay there for many hours or even many days, even weeks. And while the treatment is again going to be platelets, the problem is that the circulating abciximab can grab onto these platelets as well and destroy those. So you may need to give lots and lots of platelets. So that, my friends, is the end of this lecture on reversing anticoagulation. I hope it was good, and if you have any questions, please feel free to comment. Thanks. Bye.